My colleague, Dr. Francisco Arancibia, will make the introduction.
Thank you, Charles de la Cruz. I am Francisco Arancibia, ALAT president, and it's a pleasure to participate in this webinar. By way of introduction, antimicrobial resistance is one of the top global public health in the developed threats. It is estimated bacterial antimicrobial resistance was directly responsible for 1.27 million global deaths in 2019 and contributed to 4.95 million deaths. The misuse and overuse of antimicrobial in human, animals, and plants are the main drivers in the development of drug-resistant pathogens. In addition to death and disability, antimicrobial has a significant economic cost. The World Bank estimates that antimicrobial resistance could result in the 1 trillion additional healthcare costs by 2050 and 1 trillion to 3.4 trillion gross domestic products lost per year by 2030. But the incidence in the prevalence of MDR organisms vary according to the region of the world, including countries in Latin America. In this webinar, we have 4 important speakers. The Dr. Nathan Dan is graduate of Stanford Medical School, received fellowships training at the University of California, San Francisco, and is a pulmonary critical care medical physician at Intermount Health, Salt Lake City, Utah. Dr. Dan is a professor of internal medicine, University of Utah. His research focuses on the improving outcome in patients with community-acquired pneumonia, which includes development followed by deployment of electronic clinical decision support. And Dr. Chiagosi Pekens is an assistant professor in the Division of Pulmonary and Critical Care at Northwest University Feinberg School of Medicine and serves as an attending physician in the Medical Intensive Care Unit. As a clinical translation research, Dr. Pekens studied the role of the respiratory tract microbiota in the disease pathogenesis and host resilience in patients with pneumonia. She also has an interest in the culture-independent methods to improve the diagnostic and management of pneumonia and sepsis in ICU. Dr. Charles, continue, please.
Thank you, Francisco. And our 2 other speakers, you'll hear first from Dr. Adrian Secato, who is a physician, pulmonologist in internal medicine. He's done many studies in regards to translational clinical studies on patient outcomes. Currently, he directs the respiratory infection department in the Latin American Thoracic Society and a treasurer integrated research program at CEPAR and member of the ATS pneumonia group. And then our final speaker is Dr. Laura Pulido, who is a pulmonologist, graduated from the University of Buenos Aires, and currently resides in Rosario, Argentina. Her focus is on research, vaccine, and antibiotics, and actively involved in coordinating the respiratory infection section in the Argentine Association of Respiratory Medicine. So our first speaker will be Dr. Adrian Secato, who will be talking about impact of MDR pathogens in Latin America. So the format will be roughly 10 minutes, and then there'll be questions. And then please, if you have any questions, please use the question and answer in your Zoom, and we'll address this. Dr. Secato.
Thanks, Charles, for the introductions. Good morning, good afternoon for those coming from Latin America and also for you. I will talk to you about the impact of MDR pathogens in Latin America. I have no conflict of interest to disclose. And these are the topics that I will discuss with you today. I will talk to you about the concept of MDR and the impact of MDR on mortality risk, and also for the most common cause of pneumonia and the resistance mechanism. First of all, I would like to give you the classification of the MDR. This is the most common classifications, microbiology classifications, and we can classify pathogens in non-MDR and MDR in those pathogens that are resistant to at least one agent in 3 antimicrobial categories. Extensively drug resistant, those pathogens that are only susceptible to 2 or less antimicrobial categories, and pan-drug resistant to those pathogens that are resistant to all antimicrobial categories. A more clinical definition is difficult to treat resistance. I think that is a most useful definition, that is a term used to describe those pathogens or bacteria that are resistant to all first-line medications. And which is the impact of multidrug resistance pathogens. Here we can see the result of this meta-analysis performed with data coming from Latin America. And we can see that the presence of methicillin-resistant Staph aureus, multidrug resistant in general, and also the enterobacteria producing extensive spectrum beta-lactamase increase the risk of death, reaching the 93% increase the risk. Streptococcus pneumoniae is the most common bacterial pathogen causing pneumonia, and one important resistance, probably mainly for meningitis, but also for pneumonia, is the resistance to penicillin. Here we can see that in Latin America and also in US, this resistance reached the 20% of isolations. And another important resistance of Streptococcus pneumoniae is the resistance to macrolides. More or less has the same distribution that penicillins. And one important thing about the macrolide resistance is the mechanism of resistance. There are 2. One is a ribosomal mechanism, and the other is mediated by efflux pump. The ribosomal mechanism is most common in South America, mainly in Colombia, in Peru, and in Venezuela. And the efflux pump is most common in North America and also in Argentina. That is important because the efflux pump is a mechanism resistance that could be dose dependent, and the ribosomal mechanism is not dose dependent. Another important thing about the Streptococcus pneumoniae is that the resistance is related with the serotypes, and the serotypes that are included in the conjugated vaccine. We can see here, probably here in the case of Chile, that's the decline of resistance with the decline of those serotypes included in the vaccine. Another important pathogens causing pneumonia is Staph aureus, and mainly methicillin-resistant Staph aureus, because this pathogen is not covered by the first-line agents commonly used as empirical treatment. And here we can see the results of the GLIMP study. This was an international observational cohort that includes data from all around the world. We can see that the resistance of Staph aureus, the incidence of MRSA was around 5% in Latin America and also in North America. And if you're taking into account only those patients with a positive culture, this number is high, is reaching around 15% of all them. Here is the resistance of Staphylococcus aureus to oxacillin, to methicillin. And we can see that the incidence of these pathogens is really high for Latin America. We must say that in the last ALAT guidelines for nosocomial pneumonia, 25% was the cutoff suggested for cover these pathogens in the empirical treatment, and in mostly countries in Latin America, we have a higher number of 25%. Another pathogen that is not covered by the empirical treatment is Pseudomonas aeruginosa. Again, we have here the result of the GLIMP study, and we can see that the incidence of Pseudomonas aeruginosa is around 5%, and the Pseudomonas aeruginosa resistance is around 3%. We must say that Pseudomonas aeruginosa is most common in patients with chronic respiratory disease and also in other chronic comorbidities. And here I show you the resistance of Pseudomonas aeruginosa to piperacillin tazobactam. I choose this antibiotic because it's one of the most common anti-Pseudomonal used in Latin America, and we can see that the prevalence is high. Enterobacterias is another common cause of pneumonia. That again results of GLIMP study. Around 6% of patients has pneumonia caused by Enterobacterias. If we take into account only those with a positive culture, is 17%, and 3% were MDR Enterobacterias. An important thing is that all MDR Enterobacterias were isolated with patients with polymicrobial. Here are the resistance of Klebsiella pneumoniae to third-generation cephalosporin. That is the definition of ESBL, and we can see that the resistance is really, really high for Latin America. We must say that ESBL is a severe threat for the healthcare system and for the patients. And that's the result of a surveillance trial that we can see that in the first decade of this century in Latin America, 45% of Klebsiella pneumoniae produce ESBL. That is a really, really high number. And also for E. coli, 25% produce ESBL. This is a quick screenshot of the global distribution of carbapenemase. That is probably is a problem for nosocomial pneumonia. It's less common in community acquired pneumonia, but class A is common, has a distribution worldwide, and in United States, in Latin America. The class B and class D is less common in America and most common in Asia and Europe. As conclusions, we can say that MDR pathogens are highly prevalent in Latin America. the MDR pathogens increase the risk of death. ESBL and carbapenemase are a serious healthcare problem, and vaccination may decrease the resistance rate of Streptococcus pneumoniae. At last, I would like to invite you to our annual Congress that takes place in the beautiful city of Santiago de Chile in July of this year. Thank you very much.
Thank you very much, Dr. Staccato. Maybe we have a few minutes for questions. Feel free to submit your question and answer in Zoom. And for the panelists, if you have any questions, feel free to raise your hand. So Dr. Staccato, it was very interesting that certain MDRs are more prevalent in Latin America compared to the US. Places like Europe and Asia also have higher incidence of MDR. Do you know why that is? Is it because of the antibiotic use patterns practice?
Yeah, probably it's related with the overuse of antibiotics, not only in humans, also in animals. That's in the agriculture is most used antibiotic, and probably that is the cause. Also in all the countries, I show you all map from resistant map. You enter in this page, you can see also the use of antibiotic, and in all countries with high incidence of resistance of MDR as an overuse or most use of antibiotics, not only for humans, also for animals. That I think that is probably the common cause of the high rates of resistance. Yeah.
Thank you very much. Just for time, we're going to move on. Dr. Sibia, for the next person. Thank you very much.
Thank you.
Yes. Okay. The next presentation is use of risk factor score and electronic tools to identify MDR pathogen for Dr. Nathan Dunn.
Yeah, I think we're seeing another screen. Yeah, that's good now. And I think if you did a slideshow. Perfect.
Dr. Nathan, your microphone is muted.
All right, let's unmute me. Thank you very much to Charles for this kind invitation, and thank you to Adrian for starting us out with that excellent talk. I've been asked to speak on the use of risk factors, scores, and electronic tools to identify multidrug-resistant pathogens, which we have done in Utah through work with electronic clinical decision support. I am in pulmonary critical care in Utah, United States. I have no conflicts of interest. My work was sponsored by two different AHRQ grants. So pneumonia is a real-time electronic clinical decision support tool that operates in the emergency departments of our healthcare system. It actually deals with several aspects of care with patients in community-acquired pneumonia. First of all, it helps in diagnosis by identifying patients who might have pneumonia and providing diagnosis decision support. Secondly, it provides objective severity of illness stratification tools to recommend site of care. And then for the purpose of today's seminar, it identifies risk factors for resistant pathogens using the DRIP score, which I will be talking about here. It also, beyond identifying the risk factors, it recommends emergency department administration of antibiotics tailored to the site of care and the likely pathogens as scored by DRIP. It recommends appropriate microbiology studies, which are also tailored to site of care and the DRIP score, but it always allows for a clinician judgment, the room to opt out, disagree, and provide their reasoning. And for those who want to learn more about this electronic tool, we published results as we spread this across our healthcare system back 2 years in the Blue Journal, as cited here. So there are about 24 risk factors for drug resistance that have been identified in multiple papers. You can see that they're divided in this figure into acquisition, lower tract invasion, selective pressure, which is antibiotic use that Adrian just mentioned, and also patients who are colonized with and immunosuppression makes it more likely. But 24 factors are very difficult for a bedside clinician to deal with when you are seeing a patient in the emergency department or one who has just been admitted to the hospital. The American Thoracic Society Guideline Committee in 2019, of which I was a member, recommended 3 different things for your consideration. One was the prior isolation of multidrug-resistant infections, especially from the respiratory tract. Secondly, exposure to multidrug-resistant pathogens, meaning that a person has been in the hospital or some type of long-term acute care, and then selective pressure from recent intravenous antibiotics. And so these 3 factors all work together to make it more likely to have a multidrug-resistant pathogens. The guidelines, however, also said that instead of using these 3 factors, to use a locally validated system of risk factors, and I'm going to be showing you one of those, which is the DRIP score that I mentioned earlier. So the DRIP score uses 10 different factors, not 24, but 10 different factors that in our database and in validation databases appear to be the most important. And so it's a point system with 4 or more in our database being associated with increased risk of multidrug-resistant pathogens. So it's prior antibiotic use in the previous 60 days, long-term care, interestingly, tube feedings, which is a marker probably for aspiration and general debility in patients, and then a prior drug-resistant pathogen in the last year. Previous hospitalization, underlying lung disease, poor functional status, gastric acid suppression, which means a proton pump inhibitor, or perhaps one of the H2 blockers, somebody who's receiving wound care, and then even if it wasn't invading the lung, prior MRSA colonization somewhere in the body or in the nasal tract. So you add these up, and the total points possible are 14, 4 or more correlate with increased likelihood worthy of treatment. So we looked at the DRIP score in our validation database, which was outside of Utah. We used a database from Scottsdale, Arizona, Mayo Clinic, and also University of Connecticut. And we compared DRIP with the now discarded HCAP, healthcare-associated pneumonia one, and there are several others, Shindo from Japan, Niederman, and so forth, Aliberti from Italy. And in our database, the area under the curve for DRIP was better than the other scores that were available at the time we made this comparison. I think probably a more clinically meaningful way of looking at this is the same data presented in this graph. So this shows that with a DRIP score of 4 or more in patients in a database with DRIP, only 6% of them had inadequate specimen, meaning that the empiric antibiotics did not match up with the eventual cultured pathogen, where there was overtreatment in 12.5% of patients. And this shows there's a 2-to-1 ratio. In order to not miss too many patients, you have to overtreat a little bit to get that. But compared with HCAP, for example, which had double the amount of overtreatment and these other ones, drip had relatively less overtreatment. And the issue with patients and countries and hospitals having more multi-drug-resistant pathogens is this overtreatment drives resistance over time. And so if you don't overtreat as many patients, but you're still getting most of the ones who need it, that's much better for the long term, saves toxicity as well as problems for the individual patient. Now, the DRIP score is in widespread use. It is one of the top traffic programs on MD-Calc. MD-Calc is a free program. You can subscribe to it, but it's also, you just type in MD-Calc on your cell phone or on your any computer, and it'll come up. And if you just search under DRIP score, there comes up an interactive tool with those 10 elements, and you click the positive ones and leave the negative ones there, and the DRIP score comes up. We have a number of other medical centers in the United States have implemented this and had good success with it, including Loyola Massachusetts General Hospital in Boston and the University of Wisconsin. And so there have been multiple validation and implementation studies. So we also compared, and by the way, a lot of this work and some of these slides are from my colleague, Dr. Brandon Webb, who some of you may know, who really led the DRIP development. So we actually compared this with what the 2019 guidelines said, and these are the sensitivity, specificity, and so forth. And so in our validation database, the sensitivity of DRIP was much better, while the negative predictive value was similar. So in our healthcare system, DRIP actually performs better than what was recommended in those 2019 guidelines, which were those 3 factors that I mentioned earlier. So how do you use DRIP in clinical practice? So we routinely, and we have order sets that are pre-checked for this. So anybody with an elevated DRIP score, again, 4 or more, should have a nasal swab for PCR performed. And when that is negative, that has a very high negative predictive value for MRSA pneumonia. So then you just stop the MRSA antibiotics. And if the patient isn't that sick, you don't even initiate vancomycin until you've got the PCR back. Unfortunately, a positive result has relatively low positive predictive value, but if it's negative, you're done with vancomycin or linezolid. Secondly, there's reasonable evidence, at least in low prevalence settings, that you can discontinue broad spectrum antibiotics if all your cultures are negative at 2 to 3 days and the patient is improving. So if you do put somebody on piperacillin, tazobactam, and vancomycin, if you haven't found it, generally these bad pathogens are easier to culture than some of the ones like pneumococcus, which are a little more fastidious. And so you don't just stay on those broad spectrum antibiotics for long courses if all your cultures are negative. Now, very importantly, the DRIP score was developed in the United States, where all but a few hospitals have relatively low incidences of multi-drug-resistant pathogens. The VA system, ours, and many others, it's only 2 or 3%. And what Adrian just presented is that it's much higher in Latin America. Our group would love to have somebody in a high incidence area in Latin America take on a project using your database and validating the DRIP score in your high prevalence area. And you can look me up in my email, and we'd love to hear from you and work with you, because we actually don't know how this would work in Buenos Aires and other parts of Latin America. So that would be great. And this, getting back to the e-pneumonia clinical decision support tool, the wonderful thing about this is that with MD-Calc, you basically have to do it by hand. But using the electronic medical record, the e-pneumonia actually pre-populates. So it can recognize when a patient's had a prescription in the previous 2 months. It can recognize when a patient has been hospitalized. It can recognize whether a gastric tube is in place based on whether or not the chest X-ray showed a tube, whether they came from a nursing home and so forth. And so it pre-populates this, so it makes it much easier. But then if the computer didn't catch everything that the patient might have had, the doctor at the bedside can just check this, or if it thinks it was wrong, uncheck it. And it's just a much quicker and easier thing for a bedside clinician. And that's the beauty of real-time electronic clinical decision support. So in summary, I want to thank everybody on the pneumonia team at Intermountain Health. A picture of our hospital and the beautiful Wasatch in the distance. And I will put my email in the chat. And again, we would love to hear from you. I've been down to Buenos Aires twice, working with Carlos Luna and the team there, and spoke at the Congreso one time. And we'd love to collaborate with somebody. What we think is that if it was validated in a high incidence area, we might need to change the set point, what the criteria is, instead of 4 points and adjust it. But we think that probably these risk factors are international, and we would just need adjustment for a local site with different incidents. I'll be finished there and maybe open to any questions if it's okay with Charles.
Yes, Francisco. Any questions from our Zoom audience, right, or panel?
One question. In the word of the Anthony Torres, the best scored, they indicate antibiotics for resistant germs over 5 points. In DRIP score, what is the high score?
So I'm not sure I followed the question. A high score on DRIP is 4 or more, and less than 4 is low risk. Again, in a 3% incidence population. And it is likely true that the higher you get from 4, the increase the likelihood of the multi-drug resistance, although for simplicity, we have a binary cutoff at 4.
Okay.
I would like to ask you, Nathan, may you adapt this score to probably a Latin American healthcare system, because you have many points that is not common in hospital in Latin America, or some data is not easily available, such as colonizations in patients. Do you think that could you adapt this score?
Yeah, well, I mean, yeah, you need prior culture results and prior information. We are part of a healthcare system in the United States. You know, on the other hand, there's advantages. There's national healthcare systems. I'm not, of course, familiar with the health system in Argentina and know specifically. But what I'm saying is that I think the risk factors are probably similar. The one that I have seen that's potentially different is that there may not be as many long-term care facilities in some countries. They may not have the system of nursing homes that the United States has. And so that probably is a bigger difference. I think in terms of the cultures and the colonization, that's a matter of having some type of longitudinal database where you can gain that information.
Yeah, thank you.
Thank you very much, Dr. Dean. That's a great tool, and it's fascinating with a new predictive model. Looking forward to how it applies to other countries. So our next speaker is Dr. Laura Polida. Well, she has her slide up. She'll be talking about some new antibiotics covering these MDR pathogens.
Bueno, hola, ¿me escuchan? Creo que sí. Bueno, muy buenas tardes. Yo lo voy a dar en español y espero que salga bien la traducción abajo. Bueno, me tocó un tema bastante controversial. No tengo conflictos de interés y creo que quería comenzar con lo mismo que ya había dado el doctor Francisco Arancibia, justamente sobre resistencia antimicrobiana. Vemos que en el 2019, como dijo él, costó más de 5 millones de muertes casi, y para el 2050 se prevé más de 10 millones de muertes por la resistencia antibiótica. Y justamente los nuevos antibióticos surgen como una posible solución, ¿sí?, a este problema, que en realidad debemos ser estrategas, porque no solo está tener el problema, sino tratar de hacer la profilaxis, diríamos todos los vacunólogos, lo más que se pueda. Entonces, sabemos que una de las causas de la resistencia antibiótica es la falta de tratamiento adecuado. Pero si nos ponemos a ver, sobre todo en este estudio de Silionis, donde se evaluaron justamente pacientes hospitalizados por neumonías adquiridas en la comunidad, o de causa neumocóxica, durante el periodo de 20 años, 1997 a 2016, donde justamente el outcome primario fue la mortalidad a 30 días, y este estudio fue retrospectivo, y justamente no se vio una gran diferencia, ¿sí?, en cuanto a la mortalidad, del 8%, y se mantuvo. Y a lo mismo la prevalencia no tuvo una variabilidad muy grande. Pero si evaluamos por subgrupos, por ejemplo, por número de comorbilidades o por tratamiento adecuado, estos números cambiaban. Justamente, si tenían más de una comorbilidad, ya pasaba del 4 al 9%, y si el tratamiento era adecuado, la mortalidad bajaba un 7%, pero aquellos que recibían tratamiento inadecuado subía al 25%. Lo mismo, sí, en este estudio de Shindo del 2015, donde se evaluan en 10 instituciones japonesas pacientes hospitalizados por neumonía adquirida en la comunidad, se vio que aquellos que recibían un tratamiento adecuado tenían una mayor supervivencia que aquellos que no tenían un tratamiento inadecuado. Entonces, para seguir jugando, la epidemiología de la neumonía adquirida en la comunidad se dice que por patógenos multiresistentes es solamente de un 6%, ¿sí? Y esto entra en la cabeza el grupo PES, de Pseudomonas aeruginosa, enterobacterias con beta-lactamasas de espectro extendido y Staphylococcus meticillium resistentes. Justamente, esto es un 6%, pero más de un tercio de ellos reciben antibióticos de amplio espectro. Entonces, cito este estudio de Jones del 2020, donde justamente se evaluaron neumonías intrahospitalarias nosocomiales recibiendo tratamiento empírico estándar versus tratamiento empírico para Staphylococcus aureus meticillium resistentes, y donde se evaluó que esto aumentaba el riesgo ajustado de muerte, había más fallas renales, infecciones secundarias por Clostridio difficile, infecciones secundarias por enterococo vancomicina resistente y por gram negativos. Entonces, para no olvidar las raíces, ¿sí?, en este estudio de Torres del 2021, no solo hace falta los factores de riesgo, ¿sí?, tanto para Pseudomonas como para Staphylococcus aureus meticillium resistente, sino también hablamos de severidad para poder para poder iniciar un tratamiento empírico para patógenos como Pseudomonas o Staphylococcus. Metiéndonos en tema, me gustó mucho este timeline de los antibióticos, ¿sí?, de los nuevos antibióticos desde el 2000, que empezamos con Linezolid, con toda una línea anual de todos los antibióticos que fueron saliendo. Esto fue del año pasado de Shensek, que lo imprimió en Moléculas, en la revista Moléculas. Y metiéndonos más en temas, ¿sí?, vamos a empezar con los nuevos antibióticos para neumonía adquirida en la comunidad, ¿sí?, donde vemos, obviamente están todos, la lista, ¿no? La idea no es dar una clase sobre cada uno, ¿sí?, sino hacer un point en los más importantes. Empecemos con la Famulin, que es de la familia de fluoromutilina, sí, tiene actividad en contra de Streptococcus pneumoniae, Haemophilus influenzae, clamidia, Staphylococcus aureus meticillium resistente, Enterococcus banco resistente. Fue aprobada por la FDA del 2019 y hay dos estudios pivotales que son el LIP1 y el LIP2, el LIP1 endovenoso y oral y el LIP2 solo endovenoso, donde justamente los dos estudios fueron de no inferioridad en respuesta clínica para neumonía que tiene en la comunidad versus moxifloxacina. Siendo con la omadacidina, también es un bacteriostático, es una modificación de la aminociclina, tiene actividad en contra de Streptococcus pneumoniae, tanto penicilino resistente como macrolídeo resistente, a bacilos gram negativos, anaerobios y Staphylo aureus, y tiene un poquito más de concentración que la tigecyclina, y también fue aprobada en el 2019. También hay un estudio de no inferioridad, en fase 3, con la moxifloxacina, donde justamente se evaluó que no hubo inferioridad en cuanto a la respuesta clínica versus el tratamiento estándar con moxifloxacina. Por último, la ceftaroline, que es una cefalosporina de quinta generación, ¿sí? Que en su espectro de actividad incluye todos los patógenos asociados frecuentemente con neumonía adquirida en la comunidad, tiene actividad bactericida contra macrolídeo resistente Streptococcus pneumoniae, también para el espectro extendido de beta-lactamasas, la de Klebsiella pneumoniae, Escherichia coli y Staphylo aureus meticilino resistente. Tomando el estudio de Bassetti, donde justamente habla de pacientes hospitalizados en cuidados intensivos, los patógenos más importantes o preocupantes son los bacilos gram negativos, Pseudomonas aeruginosa, Acinetobacter baumannii, Klebsiella o enterobacterias. Justamente las nuevas drogas se caracterizan por un amplio espectro y resistencia a las beta-lactamasas y a las bacterias resistentes a carbapenems. La mortalidad de la neumonía nosocomial y de la asociada a ventilador ronda entre el 20 y el 50%, y justamente en algunos estudios se dice que hasta un 75% pueden ser causadas por patógenos multiresistentes. Esto también es un cuadro donde resume todos los nuevos antibióticos aprobados para neumonía por patógenos gram negativos, desde el ceftobiprole hasta a todas las combinaciones de impenem-relebactam. Vamos a hacer hincapié en los estudios más importantes sobre estos antibióticos. En este mismo estudio, este cuadro me pareció muy lindo, donde justamente se ve el grado de actividad de cada uno de los antibióticos, con en rojo lo que no tiene actividad para los diferentes gérmenes, gris una actividad variable y verde actividad. Empecemos con el ceftobiprole, una cefalosporina de quinta generación que también tiene actividad contra la mayoría de los patógenos causantes de neumonía adquirida en la comunidad, incluido Streptococcus pneumoniae, Haemophilus influenza, Klebsiella o Staphylo aureus meticilino resistente. Cito un estudio randomizado de doble ciego donde se comparó el ceftobiprole con ceftriaxona con o sin linezolid para el tratamiento de pacientes con neumonía adquirida en la comunidad que requirieron hospitalización. Y justamente se probó que el ceftobiprole no fue inferior, al comparar con ceftriaxona linezolid, en todos los outcomes clínicos y de erradicación microbiológica, sugiriendo que el ceftobiprole puede tener un rol potencial para tratar pacientes hospitalizados con neumonía adquirida en la comunidad. Citando otro estudio, que es el ASPEN-NP, que también fue un estudio randomizado, controlado, doble ciego, fase 3, de no inferioridad, donde se comparó para el tratamiento en pacientes con neumonía nosocomial, ceftalozane, tazobactam versus meropenem, donde justamente también no fue inferior ceftalozane, tazobactam versus meropenem, tanto en la mortalidad por todas las causas a los 28 días, en el rescate, en la erradicación microbiológica y en la cura clínica no fue inferior a meropenem. Otro estudio, que es el estudio REPROVE, que evaluó también, es un estudio randomizado doble ciego, fase 3 de no inferioridad, donde se evaluó a aquellos pacientes con neumonía nosocomial, incluida también la neumonía asociada a ventilador, del tratamiento de ceftazidime avibactam versus meropenem, donde justamente este último no fue inferior a meropenem para el tratamiento de esta neumonía nosocomial, y tanto en la cura clínica como en la erradicación microbiológica, lo que soporta que puede ser una potencial alternativa en aquellos neumonías nosocomiales causadas por patógenos gram negativos. Otro estudio, sí, que es el APEX-NP, donde se evaluó el cefiderocol contra cefalosporina versus el meropenem en dosis estándar y infusión de aquellas infecciones nosocomiales por gram negativos. También fue un estudio de randomizado doble ciego de no inferioridad, donde justamente el cefidricol no fue inferior al meropenem en términos de mortalidad a los 14 días, para aquellos neumonías nosocomiales a gram negativos. Esto también sugiere que el cefidricol es una opción potencial para el tratamiento de estos pacientes, sobre todo aquellos que sean los gram negativos multiresistentes. Otro estudio, que es el Tango 2, un estudio randomizado, donde evaluó la efectividad y la seguridad de meropenem vabobractam versus la mejor terapia disponible para pacientes con infecciones por enterobacterias resistentes a carbapenem. En cuanto al mejor tratamiento disponible, incluía monoterapia o combinación de polimixinas, carbapenem, amiloglucosis o tigecyclina, o monoterapia con ceftazidime avibactam. Se demostró que en este estudio la terapia con meropenem vabobractam en este tipo de infecciones se asoció a una mejoría en lo que es la cura clínica, descenso de mortalidad y reducción de nefrotoxicidad comparada con la mejor terapia disponible. Este estudio, el último, es el RESTORE-IMI-1, justo es un estudio multicéntrico, randomizado y doble ciego, donde se comparó la eficacia y la seguridad de imipenem relebactam versus colistin imipenem en pacientes que tenían infecciones por bacterias no susceptibles a imipenem, pacientes hospitalizados con neumonías nosocomiales o asociadas a ventilador que se complicaban con una infección intraabdominal o infección del tracto urinario, y eran causados por patógenos justamente que eran no susceptibles a imipenem. Se hizo un estudio randomizado 2-1 con tratamiento de 5 a 21 días con imipenem relebactam en un grupo y otros colistin más imipenem. Justamente la última combinación imipenem relebactam fue preferible, ¿sí? Para el tratamiento de estas infecciones, ya que la eficacia fue comparable, pero tuvo mucho menos efectos adversos, como la nefrotoxicidad en la cabeza, que el colistin imipenem. Entonces, habiendo dado un paseo por todos los estudios de los nuevos antibióticos, tanto para neumonía adquirida en la comunidad como para aquellas nosocomiales y asociadas a ventilador, tenemos que justamente tener muy en cuenta los targets farmacocinéticos a donde tenemos que ir y hacer más estudios en vida real, clínicos en vida real. ¿Por qué? Para justamente tener la importancia en la posición de estos nuevos agentes en la práctica clínica. Justamente un buen uso de los antimicrobianos actuales y un uso inteligente de estos nuevos agentes, esta combinación puede ser la clave para mantener los niveles de resistencia lo más bajos posibles. Y esto me gustó porque justamente está incluido dentro de esto, de la inteligencia artificial, no la podemos dejar de nombrar hoy en día, justamente que habla del diseño de estos modelos predictivos, ¿sí? Para directamente asignar moléculas a sintetizar, y en este caso, este artículo habla de Nature, habla de la Acinetobacter baumannii como target de la OMS. Y esto, para hablar un poquito de Argentina, hay un grupo que se llama INVERA, que es Investigación para Resistencia a Antibióticos, ¿sí? Que está formada por infectólogos para la investigación, educación y asesoramiento en lo que es resistencia antimicrobiana, y junto con ellos estamos haciendo una encuesta que invito, y perdón que tome esto, pero invito justamente a hacer una encuesta a través del QR para evaluar la autopercepción, ¿sí? Del nivel de conocimiento, ¿sí? Del uso responsable de antibióticos, ¿sí? Si no evaluamos sabemos que la prescripción de antibióticos, en nuestro caso en Argentina, es desde los médicos, ¿sí? Y se va un muy mal uso de los antibióticos actuales desde los médicos mismos, desde médicos de atención primaria, neumonólogos, clínicos y gerontólogos, etc. En muchas especialidades no se está haciendo un uso correcto, entonces vimos que es bueno evaluarlo a través por lo menos de una encuesta a los mayores sectores de salud lo más que se pueda. Bueno, muchísimas gracias. Yo también hago propaganda de todos los congresos y sobre todo del 52 Congreso Argentino de Medicina Respiratoria que se va a hacer en la ciudad de Mendoza, Argentina, entre octubre y noviembre. Están todos obviamente invitados. Muchas gracias.
Thank you very much, Dr. Polito. Very interesting talk on the new antibiotics. I don't know if we have any time for a quick question from the panel. Anybody? Let me see if there's anybody here. My quick question, Dr. Pulido, how easily accessible is it at your place with these new antibiotics? Is it easy to get?
Yes, here this combination of antibiotic is how to say is determined by infectologists, no by antibiogram. If you are, I think we got late to the cultures, and I think only the infectologists are the ones who prescribe this selected combination of antibiotics, and I think we get late because of the duration of the clinics of the patient when we set to the culture or the antibiogram. I think we have the 50% of the patient alive, but I think we had to accelerate the test in the hospitalized patients to get to the cultures of these prompt antibiograms faster.
Thank you very much. I think that's very timely for me to pass on to Francisco for the next talk. Thank you very much, Sarah.
You're welcome.
Okay, the next speaker is Dr. Chagosi Pekent with the topic, the rapid diagnostic dose.
Okay, thank you for the kind introduction and thank you for the invitation. Can everyone see the full presentation mode? Great. And I'm sorry if this goes a little bit over, but I will try to be like efficient with my time. So I'm going to talk about rapid diagnostic tests in severe community-acquired pneumonia, and I think the previous speakers very nicely set the stage for this talk. The utility of rapid diagnostics is kind of multifactorial, but I think, you know, to best address the rapid rise in resistance, we need to be better antibiotic stewards, and rapid diagnostic tools can help us achieve that goal. So, you know, previous studies have questioned whether or not it's important to even identify the etiology of community-acquired pneumonia. Many of these studies are now dated, they're 20 to 25 years old, but they looked at patients who'd had a sputum culture and routine testing and compared them to patients who had empirical treatment with antibiotics. And they looked at outcomes like mortality, number of antibiotic changes, hospital length of stay, C. diff, etc. And they actually did not find a difference in those outcomes. So some people may say, you know, is it truly important to even use rapid diagnostic tests and really pinpoint the cause of pneumonia? But I would argue that, you know, yes, now that we have newer tests, now that we have newer implications for the result, it is important to identify the exact cause of pneumonia. And I've listed some of the reasons here. So primarily, we're interested in antibiotic stewardship. We know that risk factors can kind of give us an idea of whether or not someone's more likely to have a resistant organism. But, you know, those aren't always matching up with the true pathogen identified. So very sensitive tests can help us narrow antibiotics in a timely manner and halt the resistance or the development of resistance in certain populations. There are public health implications. So if you detect COVID, you know, we're most familiar with that. But also if you detect Legionella, that has implications on the community and what you do with the result. Some patients or some populations have prognosis affected by the type of organism that's detected. If you detect Pseudomonas versus if you detect a drug susceptible strep, those have different implications on treatment and outcome. And then if you are on the fence about whether or not someone has community-acquired pneumonia and your testing is negative, it may push you towards exploring alternative diagnoses because we know the clinical diagnosis of pneumonia in itself is very challenging. And then it's important for epidemiologic purposes to always understand what are the most common causes of pneumonia. So before, you know, we see a lot of strep pneumo in the United States with vaccinations, declines in cigarette smoking, et cetera. We don't see that as much. And so it may prompt us to switch our empirical antibiotic treatments. So for all these reasons, we do care about understanding the etiology of pneumonia. This is a study from 5 US hospitals. And the purpose of this, the figure is from that study. And the purpose of the study was to identify the etiology of pneumonia in adults hospitalized for community-acquired pneumonia. There were over 2,000 patients enrolled, and they underwent routine diagnostic testing. So sputum, if it was available, was tested. Lower respiratory tract samples were tested. Urinary antigens were sent when available. And all of the patients had nasopharyngeal and oropharyngeal swabs. The most, kind of important or interesting finding from this study, again in the US, was that no pathogen was detected in 62% of the cases. So that prompted us to ask, are our diagnostic tests sufficiently sensitive? And maybe the answer is no, looking at this figure. Or are there other causes of pneumonia that we're not picking up? The other thing that's interesting here is that historically, strep, pneumo, H flu, staph have been predominant etiologies of pneumonia. But we see here that human rhinovirus and influenza, so viruses, are an important cause of community-acquired pneumonia. That's really important for antibiotic stewardship because there may be some patients who do not need empirical antibiotic therapy, although right now it's very difficult to identify them. So these were adults hospitalized for pneumonia. Some were non-severe pneumonia, some were severe CAP. And even in the severe CAP patients, viruses were more commonly identified than bacteria, although bacteria were present in a higher proportion of ICU patients compared to non-ICU patients. So the take home from this slide is that A, the routine diagnostics that we use may not be sufficient, and that's why we're talking about rapid diagnostics. And then B, viruses are an important cause of CAP, and so not all patients may need antibiotics, although it's really hard to parse that difference currently. So this information, this table is from a study done in 2020. It's a secondary analysis of an international observational cohort study that mainly focused on identifying the point prevalence of MRSA, but they ended up looking at all different organisms that were identified. Important again here was that a pathogen or an organism was identified only in 35% of all comers in this study, and over 2,500 patients with pneumonia were enrolled. So again, it was hard to find an organism. But importantly, when you see what you see here is that the trend is not consistent. So previously I showed that, H flu was there, strep pneumo was common, viruses were common, but that may not apply to other geographic regions. So you'll see here, strep pneumo was very common in some countries. In other countries, MRSA was present in a high rate. In other countries, Pseudomonas was the most commonly detected bacteria. And the reason why I show this is that anytime you're interpreting the operating characteristics of a rapid diagnostic test, you have to know the disease prevalence. So a lot of studies are done at a single center, maybe they're done in one city, and that may not necessarily apply to our, clinical scenario. So it's important to validate the test locally rather than assuming that because it's very sensitive in one area, it's going to be sensitive in your area. So I kind of wrote here more specifically that as the prevalence of the disease increases, the positive predictive value also increases, which makes sense because the disease is more prevalent. If the test is positive, the patient is more likely to have that disease. But the negative predictive value decreases because the test is more likely to miss patients who maybe have a disease on one end of the spectrum, like maybe a more subtle presentation of that disease. Similarly, the specificity and sensitivity tend to be affected. So I say all that to say, the data that I'm about to show should encourage us, I think, to use rapid diagnostics, but first they need to be validated, and they should always be coupled with antibiotic stewardship guidance from, an ID team, a pulmonary team, pharmacy, et cetera, in order to really understand how to best use it in your practice. Rapid diagnostic testing is an umbrella term for several different kinds of tests. Some detect antigens, some detect antibodies. Many of them are molecular, so they're detecting genetic material, and I've listed some of them here. So PCR-based testing, as we know, the DNA is denatured, the primer is anneal, and then it's extended. So for multiplex PCR testing, the primers will anneal to certain genetic sequences of a species. And if that is not present, then the test won't be positive. We have LAMP, CRISPR, transcription-mediated amplification, microarray-based testing, and next-generation sequencing. So I put this here mainly to show that this is a field that's growing very rapidly. And there are a lot of different test options to consider when you're thinking about rapid diagnostic testing. Okay, there are advantages and limitations of the test. So the advantages are that the turnaround time is on the order of hours. As we all know, when we send a culture, it takes 24 to 48 hours to grow an organism if it's going to grow, and then an additional amount of time for sensitivities. Compare that or contrast that to the turnaround time of 3 hours for a test to tell you whether or not, staph is present, strep pneumo is present, etc. Many of them are culture independent. So you need a bodily fluid or some sort of specimen from the patient, but it doesn't have to grow on culture. The test can detect the genetic material directly from that sample. Many platforms are almost fully automated, so it definitely decreases the labor needed in the microbiology lab. And then they're highly sensitive. So they may pick up low levels of genetic material of an organism that would not normally grow on culture. The limitation is the interpretation of the results. Because the rapid diagnostic test is only identifying genetic material, here we're talking about molecular tests, because they only identify genetic material, it may be residual from someone recovering from pneumonia, and it may not really tell you what's going on. There's sparse literature on cost effectiveness, so we don't truly know how it would impact finances in terms of academic centers and hospitals using the test. And then antibiotic susceptibilities cannot be determined just from a positive test for an organism. You also need a resistance marker, and sometimes the resistance markers don't even truly reflect what's going on in terms of resistance. So there are a lot of limitations from the test, and then there are some potential benefits. I do also want to mention it matters what sample you're testing. So pneumonia, as we all know, is an infection in the alveolar space in the lower respiratory tract, the lung parenchyma. So if we test anywhere along the respiratory tract, such as the upper respiratory tract, it may not tell us what's going on in the alveolar space. And we see that, in a lot of literature, that just because you detect a virus with a rapid diagnostic test from the nose or the mouth, that doesn't necessarily tell you that there's not bacteria in the lung. And then vice versa, if the test is negative from an upper respiratory tract sample, you may very well have an infection in the lower respiratory tract. So it really matters what sample you're testing when we think about pneumonia. For the sake of time, I guess I won't go through the details here, but that's the take-home point of this slide. I do want to mention that there has been some promising literature in terms of testing upper respiratory tract samples when we're thinking about ruling out MRSA pneumonia. So, pneumonia in the lung. We can rely, or at least kind of gain some insight from the results of an upper respiratory tract sample. Part of the reason for this is that a lot of the resistance from Staph aureus, when we're thinking about methicillin resistance, comes from the MECA gene. So if you detect the absence of that gene, most of the time the staph is not methicillin resistant. The MECA gene encodes a penicillin binding protein that can continue to allow for cell wall synthesis, even in the presence of methicillin. Methicillin normally binds to the penicillin binding protein and inhibits cell wall synthesis. But in the case of MECA gene expression, then that methicillin cannot bind to the unique penicillin binding protein. So with this information and with several prospective studies, again, done, in the US, we have found an excellent negative predictive value for nasal swabs to help us exclude MRSA pneumonia from the lower respiratory tract. So this is most helpful in settings with low MRSA prevalence when it's unlikely to be MRSA to start with. If you have a negative nasal swab, you can safely de-escalate anti-MRSA antibiotic therapy. We at our institution have also evaluated the use of a PCR to detect the MECA gene and staph presence on BAL fluid, and we found that to be very sensitive as well. So again, for the sake of time, I won't go through all of this, but this was a small prospective study that we did at our hospital, randomized controlled trial, randomizing patients who had empirical anti-MRSA therapy to usual care or care guided by a rapid diagnostic test that tests for MRSA on BAL samples. And what we found was that the anti-MRSA treatment in hours was significantly shorter in patients who had their care guided by the rapid diagnostic test compared to usual care, which makes sense because the usual care people are waiting for 3 days to decide on antibiotic treatment. We also saw a decrease in hospital-acquired infections, hospital length of stay, and mortality in the patients who had rapid diagnostic testing compared to usual care. The sample size for the study is 44 patients, so too small to truly be powered to look at all those outcomes, but we saw an important trend here. And most importantly, we didn't see an increase in any harm. This is an example of a multiplex PCR. So what I talked about with MRSA was a single target PCR test. This is the panel, the BioFire panel, which many of you may be familiar with. But there are 2 FDA-approved tests for multiplex PCR tests for lower respiratory tract samples, and there are several others for sputum, nasal, etc. But what I want to point out is that these panels cover many of the organisms we think about when we're thinking about community-acquired pneumonia, as well as important resistance genes such as CTXM, the MECA gene, and carbapenem resistance genes. The thing to keep in mind about some of the other resistance genes, unlike the MECA gene, is that just because you have one gene doesn't mean it's necessarily being expressed. So there's some discordance sometimes between genotypic resistance and phenotypic resistance. And then on the contrary, we know there are so many different mechanisms for antibiotic resistance, such as efflux pumps, maybe enzymatic degradation of the antibiotic, inherent resistance due to the cell wall structure, et cetera. So just because you don't have a resistance marker doesn't mean that that organism is not resistant. And that's what we see here. Again, for the sake of time, I will move past that, but that's an important thing to remember with the panels. And then we at our institution demonstrated that these panels can help with the antibiotic de-escalation, even in severe pneumonia. So this was from a study of patients who had COVID pneumonia. So they all had BAL samples. They were all intubated for COVID. We sent cultured, we sent multiplex PCR tests, and the NAT score that you see on the y-axis is just a measure of how broad the antibiotics were that the patient received. So if they were very broad, the NAT score should be positive. If they were very narrow, it should be negative. And if it was guideline concordant care, it's 0. So we see in patients who had a negative multiplex PCR test on day 0, when they had their BAL, the NAT score was positive, which makes sense because the team was worried about bacterial pneumonia. But as soon as the test came back, the antibiotic, the NAT score decreased, and it continued to decrease well past 10 days. So these tests are very helpful for antibiotic stewardship. And you'll see the test was, more positive in the patients who tested positive. Skip this because I know that we're a little bit over time. Many of you are familiar with this, but this is just, the study we did was a prospective kind of observational study. But this was a randomized controlled trial done in Switzerland, 2 different centers, done by Dr. Stoltz and her group. So this was one of the first, I believe, randomized controlled trial looking at a multiplex PCR to guide antibiotic care. And what they very nicely demonstrated was that there was a significant decrease in inappropriate antibiotic therapy in patients who had their testing or their antibiotics guided by rapid diagnostic testing. Importantly, the rapid diagnostic test was paired with antibiotic stewardship guidance provided within 5 hours. So the clinician wasn't just given the test, they were also given recommendations on what to do with the test, which allowed for antibiotic de-escalation. And then there was no harm. There was also no change in time to clinical stability or discharge from the hospital. So it was really this is not inferior in terms of mortality, but it does help with antibiotic stewardship. So to summarize, my apologies for going a little bit over, it's important to find the etiology of pneumonia. Whenever we're looking at the literature on these tests, we have to keep in mind the disease prevalence because that affects the negative predictive value, positive predictive value. Single target assays for MRSA can be very helpful on non-invasive samples like nasal swabs. And then multiplex PCR testing can improve antibiotic stewardship primarily by antibiotic de-escalation. The resistance genes have to be interpreted with caution. And then all of this needs to be paired with antibiotic stewardship, at the present time, because it's such a new test. We want to make sure we use the results wisely. And then just a big thank you to my the research team that I work with in Chicago and some of the funding. Thank you. Should I take
Thank you,
questions?
Dr. Pickens. One question.
I think that there is a question from Marco Restrepo.
Yeah.
He say, what will be the recommendation on how to integrate the rapid diagnosis and the DRIP score in clinical practice?
Oh, question for all panelists. So I guess that's a very good question. Thank you, Marcos. So, you know, the question is kind of pointing out that hasn't been studied yet. But I do, you know, think a prospective trial and incorporating the two is probably warranted. You know, I know right now rapid diagnostic tests are being compared to usual care. So I wonder if a study looking at the rapid diagnostic test in combination with the DRIP score versus the rapid diagnostic test alone would be interesting, or, you know, rather than just comparing to usual care to see how outcomes improve or change at all.
Yeah, I agree with that response. In my presentation, the most well-validated rapid diagnostic test is the PCR for MRSA, and we already incorporate that with the DRIP score so that vancomycin is either not initiated or stopped with a negative test. So I think it depends on the performance and validation of the rapid test, but absolutely the performance of PCR tests is going to be greatly enhanced if you run it on patients already at risk for drug resistance as opposed to a very low risk population, just because of the way it works in terms of true positives and true negatives. And this is where, again, as I spoke, we'd love to collaborate with some people on this call from areas that have a much higher rate of multi-drug-resistant pathogens than we do in Salt Lake City and most of the United States. Thank you for the question, Marcos.
Looks like there's a question about viral cap. Somebody wants to know what are typical X-ray findings for the panel.
In the data that I showed, it was for, we looked at the utility of multiplex PCR to help us rule out bacterial co-infection. It was for COVID pneumonia, but what we saw was that there's really no specific way to distinguish between viral and bacterial pneumonia using routine clinical parameters or radiographic findings, or even, you know, procalcitonin and other biomarkers. So that argues for, you know, more investigation into the etiology of pneumonia, because while we may see, you know, lobar consolidations more likely in bacterial pneumonia, we know like adenovirus can cause lobar consolidation as well. So it's really hard to use the radiographic finding to distinguish between the two.
Yeah. I agree with that response. We're actually interested. We're trying to think about how to study this further. There's clearly no one way of determining viral versus bacterial, but perhaps if you put everything together, the radiographic pattern, the CBC, the neutrophil count, the procalcitonin, the CRP, and symptoms, you might be able to do better. So we've been proposing that we try and look in large databases with using machine learning techniques to see whether there could be a score like DRIP for viral versus bacterial pneumonia.
That's very interesting. I think next question is about semi-quantitative measurements in some of these diagnostic tools. I guess.
Yeah.
Okay. Oh. Should I answer? I can answer that for the BioFire. So the reported use is that the semi-quantitative report is 1 log higher than the CFUs. So if you have, for example, 10 to the 6th Let me see if I can do the math correctly. But if you have 10 to the 6 on the biofire, you should have about 10,000 CFUs. So it's kind of a rough correlate, although in our practice in Chicago, we haven't necessarily seen that correlate. But that's what the literature will say. So it's supposed to somewhat correlate to the CFUs. And, you know, it would be interesting to do a longitudinal study and maybe track it over time. So if someone comes in with pneumonia, they have 10 to the 7th on the panel, and then a few days later, they have 10 to the 3rd. Does that correlate with like microbiologic clearance as well?
So Francisco and Adrian, maybe we can do two more questions and then we can finish.
Yeah. I think that probably the question of Marco, he said that what is the current practice for rapid diagnosis and severity score in Latin America? Rapid diagnosis is not widely available in Latin America, only in a few centers, and was included in the last ALAT guidelines, is sharing with European guidelines for severe pneumonia, and the recommendation is use rapid diagnostic tests when it's available in those patients we receive non-commonly treatment. No, those patients with we will use an empirical treatment different to ceftriaxone and azithromycin or beta-lactam plus an inhibitor of beta-lactam. Those patients we receive a broad spectrum antibiotics. The severity score is not used, I think, in many centers. Probably in the university center is used, but not widely used in Latin America. That is interesting because the prevalence of resistant germs is different in many countries. So we must think that probably is a good thing. I always think that a good idea is implement a combination of severity score and rapid diagnostic tests.
So the next question looks like it's we've got a few more questions about the molecular testing. Does it reduce antibiotic treatment time? Looks like one of your studies showed that, right, Dr. Pickens? Or is it just clinical decision or guided by biomarkers?
Right. Okay, I see the question. So in our study looking at the MRSA PCR, it did reduce time to antibiotic de-escalation. So in the patients who didn't have MRSA, they had a shorter duration of anti-MRSA antibiotic therapy compared to usual care. And then in Dr. Stolz's group as well, it reduced the time, the duration of inappropriate antibiotic therapy. You know, that study was done in patients hospitalized with pneumonia who had risk factors for gram-negative infections. So they were more likely to be on broader antibiotics, and it reduced the time that they were on those inappropriately. I have seen several other prospective studies looking at the same thing and finding a shorter time of inappropriate antibiotic therapy. I do know, because the second part is it just clinical decision or guided by biomarkers? Yeah.
Yeah, thank you very much. I don't know if Dr. Polito is able to speak, but Dr. Carlos Luna, hi, Carlos.
Yes, sorry. I am connected from my cellular. I have problem with my PC. Sorry.
That's all right. Hi, Carlos. Carlos has a question about severe pneumonia and availability of antibiotics, that we don't have enough for viral infection. Do you know anything new for viral pneumonia?
Yeah, I'm following the guys of Torres in 2021. I talk about the empiric treatment, be MRSA or pseudomonas. The risk factor for viruses like lymphocytosis or lymphopenia, that's we can put inhibitors, the neuraminidase inhibitors to prevent, to treat viral pneumonia as influenza. It's the most common virus that we got diagnosed here.
Thank you. Any other panelists know about new viral treatments? I know many of them are in the pipeline, but nothing really coming out yet. I think there's some failed studies, right, with RSV. And then lastly, apart from BioFire, Dr. Pickens, any other validated platform?
Yes, there are several. The study that I mentioned, that randomized controlled trial, actually used the Curetis, Curetis platform. So that's a little bit different. And there's a long list of validated platforms for sputum and nasal samples and endotracheal aspirates on the FDA website. So these are the FDA approved ones. So they've been validated. There's a long list of them on that website, but yep. So that's what I'll say about that. There are several others.
So thank you very much for all the speakers. And Dr. Sibia, do you want to say the last words? Or Dr. Chicado?
Yes, thank you for everyone, to all the speakers. We have great talks and really interesting. And for the people coming from Latin America, this is really important because we have a new vision for this problem. It's a really important problem, and we should implement new techniques and new knowledge to improve the use of antibiotics. We will improve the prognosis of patients and also the pressure of on MDR resistant. So this is really important for us and also for the healthcare system, because it's a problem, and as I say in my talk, is a severe threat for everyone.
So thank you.
Also, I would like to thanks to all ATS staff and also for ALAT staff for their support. It's really important for us.
Thank you very much, I think, for your time and overtime. I think Dr. Chicado and Sibia and everybody else will be working together for more webinar, right, and in the future. So if you have any ideas of topic, reach out to us. And thank you, Jadir, for helping us with the Zoom. Thank you, everybody.
Thank you.
See you.
Bye-bye.
Bye, thank you.